Good morning, everyone. Bone marrow aspirate concentrate is a valuable weapon in the armamentarium of regenerative medicine consultants. Today, we'll learn about the basics of bone marrow aspirate concentrate. My name is Weber Bagaria. I'm a hip and knee surgeon at Sir H.N. Reliance Foundation Hospital in Mumbai. So, if you look at the cells for the regenerative options, they are basically derived from three sources: bone marrow, adipose tissue, and the peripheral blood. And the whole regenerative medicine debate on what is better is focused on ease of extraction, the availability of these cells, the yield that we get from these products, their differentiation potential, and their growth kinetics. So, when we look at the sources of these cells, the bone marrow derived cells are usually derived from the iliac crest, and there are various modifications of a common technique. The adipose tissue cells are derived either from infrapatellar fat pad, buttocks, or abdomen. The peripheral blood cells are derived from blood using the apheresis technique. These cells are usually do not show the MSC markers unless they are in hypoxic condition, or if we do not inject a subcutaneous injection of human granulocyte colony stimulating factor. So if we have to get the mesenchymal stem cell from peripheral blood, we need to either subject it to hypoxic condition or give an injection of HGSF. So today's talk is basically focused on basics of bone marrow aspirate concentrate. So through this lecture, we'll know what are these cells, what are these concentrates, why we should use them or where we should use them, how to collect them, when we use them, and we'll also touch upon a bit of controversy about this subject in terms of nomenclature, the efficacy, the adverse event, and various products that are available and approval of these bone marrow concentrate. So, what are these BMAC or bone marrow aspirate concentrate? They are also known as bone marrow derived cell aspirate or simply BMC, which is bone marrow concentrate. Now, when we aspirate the bone marrow, it contains different kind of cells, including WBCs, RBCs, platelet, hematopoietic and non-hematopoietic cells. And when we concentrate this 60 ml of bone marrow, it would result in somewhere between 70,000 to 90,000 mesenchymal cell concentration. This is far more than the average microfracture that only releases 5 to 10 ml of unconcentrated marrow and thus contain only 500 to 1000 mesenchymal stem cells. It is of course significantly less than culture expanded cells, which are in the typical range of 5 million to 10 million. However, here I would mention two important terms: trophic and paracrine effect. These are what make the whole concentrate a powerhouse. As I said, if you look at the content, it could be platelet, red cell, nucleated cell, committed progenitor cell, hematopoietic stem cells, and mesenchymal stem cell. The entire goal is to produce a concentrated MSC HSC committed progenitor cell delivered to the treatment site. And as I said, we all know about these components or subcomponents. So stem cells are pluripotent and can convert to osteoblast or chondrocyte. Then we have got progenitor cells which convert to the target tissue and support angiogenesis, release BMP2, BMP6 and activate the dormant cells. So these are sort of a medical signaling cells. The platelets by themselves are rich source of growth factor that support proliferation and differentiation. Lymphocytes are not as powerful as platelet, but yet they play a role in migration and proliferation of endothelial progenitor cell. And granulocytes are the ones that are responsible for supporting angiogenesis through the release of VEGFs and mediate inflammation. So when we concentrate, you can look all the different type of cell increase. So there is a 61% increase in the yield of nucleated cell, 69% increase in the yield of mononuclear cell, and more than 75% yield of the CD34 cells. However, as I said, the two important words are trophic and parakine effect of this concentrate. So when we look at the bone marrow aspirate concentrate, we are not just looking at the cells that it delivers. The cells, in fact, are very small population within the marrow, only from 0.001% to 0.01%. In contrast, it does contain high concentration of growth factors, which include platelet-derived growth factor, TGF, beta, BMP2 and 7, which by themselves have reported to have an anabolic and anti-inflammatory effect. It also contains considerable concentration of interleukin-1 inhibitors, a receptor antagonist, which inhibits IL-1 catabolism. So if you look at the whole thing, the bone marrow concentrate, it contains two things. It contains cells and it also contains growth factor. And together is what makes the BMAC work. And cells, if you look at the whole thing, contains not only the mesenchymal stem cells, but also the medical signaling cell. So it's a cocktail of stem cells, signaling cells, and growth factors. And together this cocktail is useful. We will now look at how to prepare a good bone marrow aspirate concentrate. We'll look at the inventory, preparation methods, aspiration, processing, and delivery of these cells. So there are various commercially available kits for bone marrow aspirate concentration. So for example, BMC is a trade name from Tricell. We've got Smart Prep, Angel, BioQ, Arteriocyte, Magellan, MCite Elite, and several locally made BMAC concentration kits. The first step in any of these is ensuring that all the elements or all the instruments or inventory that comes in contact with the blood or the bone marrow is thoroughly rinsed. And basically, the recommended saline on table is 50 to 100 ml, and for every ml of saline, we should use 1,000 units of heparin that needs to be used. So in total, if you look at a 50 ml concentration required is 50,000 units, or 2 vials of 25,000 units for rinsing all the components. The approach used could be anterior, lateral, or posterior. A trick is to insert your needle in the line of your pelvic brim and then toggle it in the movement, and we'll just briefly see it in the video that follows. Occasionally you may need to tap in young patients when the bone is very strong, a gentle tap to ensure that you breach the first cortex of the iliac crest. This is a small video of how to aspirate the bone marrow. You'll see I've pinched the iliac crest so as to prevent the needle from slipping. Otherwise, if you look at the video, if you slip first, you just hold the iliac crest, keep a finger to stabilize your needle, find your direction, and then in a toggling movement with gentle forward pressure, you insert till you get a giveaway sensation. Keep the table at the lowest possible height to give you a good lever arm. See, once you've engaged, you will find the giveaway. Okay, and that's the direction. To ensure a high yield, it's important to use a freshly heparinized syringe. A rule of 5, 15, and 30 is followed. So that means that you would typically to ensure a 30 ml, we used 2 incision. So in the first incision, in the first go, you withdraw 5 ml, then you turn around 90 degree, take another 5 ml, and then turn another 5 degree to take another 5 ml. So 15 ml with a single insertion of needle through single incision. Then through the same incision, you put the needle in a different direction and repeat these steps to get another 15 ml. So total of 30 ml can be taken from one incision with insertion of needle twice. And then you use another incision to repeat these steps. So total of 60 ml can be garnered from 2 incisions and 4 insertions of the needle. It is important not to draw the marrow at a very high pressure, because that causes the cells to have some amount of trauma when they are coming out, and that is why it's important that you just keep the pressure at next 5 ml. So if you're using a syringe, and you start with zero. So the amount of pressure that you apply is 5 ml, and gradually put, so that the level of the marrow that you get and the level of the plunger, there is a difference of 5 milliliter in between. So that's enough pressure to get the blood at the same time, not cause trauma. So if you look at this video again, you see how I'm taking the blood out. You remove the spirit, you lock the syringe to prevent any air coming from it, and you see if you stabilize the plunger, and then see you've kept it at 5 ml, and slowly the blood starts flowing. That's the right rate it should come, not too fast, not too slow. And then you gradually do that, and 5 ml, and then stop. Now, once you have withdrawn the adequate 60 ml, you send it for the bone marrow processing, and the most common way used is density gradient centrifugation. Basically, you discard some product and retain certain product. So you discard 85% of what is not needed. And what do we discard? We discard the lower density plasma and the higher density cells, which are primarily composed of red cells. And what do we retain? We retain majority of platelets, lymphocyte, monocyte, granulocyte, and also some amount of young red cells from both the marrow and the infiltrated peripheral blood components of the aspiration. As I said, the commonest method is density gradient centrifugation, but there are various authors who have described different kind of marrow access techniques and retrieval devices. So this is an example from SPART prep. So if you look at the whole thing, the cell-free plasma is discarded, the RBCs are discarded, and the nucleated cell, which is in the second chamber bottom, is the one that is retained. And you may dilute it with the plasma slightly, depending on the amount of the volume that you need. And each company gives their own concentration levels. If you look at Harvest, Cytomedics, Smart Prep, Thermogenesis, BMC system, Biomed, BioQ, so all the comparisons are there on this, and you can see the factor is the cell yield in percentage and actual absolute count of mean nucleated cells that these guys claim to have. Now, when we look at the BMAC uses, they are different from different fields: ophthalmology, cardiovascular, vascular, and orthopedics. We primarily concentrate on orthopedics, although its use in peripheral vascular disease and certain kind of ophthalmology conditions is quite well established now. We primarily use it for different conditions like non-unions, osseous defect, spinal fusions, avascular necrosis or osteonecrosis, and for cartilage regeneration. The fact that these cells are derived from the bone marrow, from the bone, they are said to have a home advantage effect. They've got a niche, which is an internal niche, and the milieu is quite similar to this. So anywhere when we have to deal with either bone or cartilage, these cells have a better paracrine or trophic effect as per studies. So this is a simple slide of how the BMAC is used in non-unions. This for avian, where you do a core decompression and inject it in your tract along with a scaffold. Cartilage repair again for regeneration at a focal cartilage defect. The early results have been very encouraging, and enough of papers on it. So this is by Philip Hernigue and et al. And it says that the difference between the success and failure depends on the number of progenitor cells that are put at the site. Again, by Marcus Jagger, and they've talked about creating larger colonies of fibroblasts using BMAC. They've been talked of combining these bone marrow concentrate with PRP. Again, not very convincing evidence yet. One of our own papers there's on a murine posterolateral lumbar spine arthrodesis, wherein we also combined with bone morphogenic protein. Gobi et al. Along with Mahajan have published this one-step cartilage repair technique. This is how this demonstrated the improvement in the cartilage regeneration with this. A lot of papers coming in about osteochondritis dissecans and about cartilage regeneration. There's been an increasing evidence of their use in the osteoarthritis of the knee. And one area it's where it has produced the maximum results is in the use of the AVN. So the role of bone marrow aspirate concentrate in AVN is well established. There are numerous studies which has studied both the efficacy as well as the safety of this product in AVN. Now, coming to a very important thing, the controversy surrounding the bone marrow aspirate concentrate. Well, if it matters, it produces controversy. And what are the controversies that currently plague the whole thing? First of all, it's a complete alphabet soup. You've got different people saying different terms: BMAC, BMCs, MSCs, BMDCs, which is bone marrow derived cell, BMSC, which is the bone marrow stem cell. And then there is always a debate between the hype and the hope for these products. Now, for us as an orthopedic surgeons, what do we look at? Whether it is effective and how does it compare to alternative? But most importantly, is it safe enough? So the two thing that is currently on the top of my mind is its effectivity and its safety. Some clarity on the terminology would help. Some reduction in hope and rationalization of hype would help in this era. So safety is well established. If you look at this big series of 101 patients, initial studies, Henrich et al., it clearly says that the safety is not an issue with these things. However, when we come to efficacy, you'll see that there is absence of confidence in this field. This is from one of the leading companies, the Smart Prep centrifuge system, and it says clearly on its website that the safety and effectiveness for BMAC in vivo indication has not been established. So you see that there is still lack of a concrete evidence of their usefulness, and that is why the confidence in the people who use it is lacking when using these products. A bit more about the alphabet soup. So BMAC stands for bone marrow aspirate concentrate. It is similar to BMC, which is the bone marrow concentrate. BMDC stands for bone marrow derived cells. BMSC stands for bone marrow stem cells, which is a term that should be restricted by the definition of the International Stem Cell Society of when the cells contain a certain number. And now there is a debate between the MSC original versus the re-Christian. So originally MSC stood for mesenchymal stem cell, and they're now called as medical signaling cells. So for us as an orthopedic surgeon, what is BMAC? So BMAC or bone marrow concentrate is a mixture or a cocktail of bone marrow derived cells along with certain growth factors. Whereas BMSC, which is the bone marrow stem cells, are the bone marrow cells which are expanded in culture and meet the criteria laid down by ISCT. What are the alternatives to BMAC, which is the bone marrow aspirate concentrate? Is of course we can expand them. So culture expanded BMSCs. We've got adipose derived or stromal vascular fraction. We've got culture expanded adipose derived cells, peripheral blood cells, allogenic, and the debate about the umbilical cord derived stem cells and embryonic stem cell. So all in all, if you look at the take home message, when we give bone marrow concentrate, it works on dual principle. It provides certain degree of cells, certain number of cells, and a certain amount of growth factor to kickstart the reparative process. Aspiration techniques are important to get a high yield. The principal technique for concentration is density gradient centrifugation. It can be combined with scaffold to enhance the healing. Since these cells are derived from bone marrow, so they have got a home ground advantage, or called a concept of niche, when we put it into orthopedic use. And currently these orthopedic use include avascular necrosis, non-unions, osseous defects, and osteochondral defects. There are still unknown unknowns, and there is a lot of opportunity and things waiting to be explored. I thank iBoss and welcome any questions on the subject. Thank you.